Miss Tommy?
Yeah, hello.
Yeah. Now you are audible. Yeah.
Okay. So, shall we start?
Yes, we can start. Yeah.
Okay. Okay, so a very good evening to one and all present here. I am Soumi Acharya from MedPiper, and I welcome every one of you present here today, including our respected speaker, Dr. Shai Sukar, who has graciously agreed to lead this webinar on role of private practitioners in the pandemic, how to help patients as well as grow your practice. In order to set some context to the webinar, I will start off by introducing you to MedPiper technologies, highlight our objective, and briefly explain the flow of events. So, some of you present here today might be aware of MedPiper and Journalment and the work we do. But to those who are new, Journalment is a healthcare provider-focused digital publisher. We believe well-informed healthcare providers deliver better patient outcomes. So, through partnerships with over 30 leading medical industry companies and various medical associations, we curate and disseminate the stories and research that matter most to our nearly 65,000 verified recipients, such as physicians, dentists, nurses, and other healthcare professionals. MedPiper is a health tech company that uses technology to connect doctors and healthcare professionals with hospitals and healthcare organizations for duty vacancies, clinical assignments, and partnerships. Our platform helps doctors with resources to enhance their professional skills and network with peers in the medical field. Our objective is to unify healthcare data and minimize the information symmetry in healthcare, especially among practitioners. To achieve this target, MedPiper is also building a professional network for pre-verified and peer-authenticated professionals and practitioners. On the platform, we use knowledge maps, AI, and blockchain technology to enable the verification of profile credentials by peers, educators, and employers, and match those verified profiles to the job requirements. In addition to this, MedPiper's service includes providing a one-stop go-to API solution for rapidly scaling digital health companies. We are currently working with Tata Health, Seven Sugars, Apollo 24/7, DocSat, to name a few of them. In addition to this, real-time provider data verification and network monitoring, MedPiper's expanded platform also offers end-to-end solutions to healthcare organizations. Now, I would like to introduce our speaker to the audience. Dr. Sai Shankar is a pediatric intensivist and neonatologist with 15 years of experience in general pediatric and intensive care practice. He is a strong believer in data-driven care and co-founder of DocCare Health, a remote patient monitoring and telehealth health tech platform. Dr. Sai is currently working on cancer genomics and artificial intelligence, machine learning, and fuzzy logic in healthcare. With that note, I would like to take this opportunity to thank our speaker. Thank you so much, Doctor, for joining us today for this session.
Thanks, Somi. Can I go ahead?
Yeah, sure.
Yeah, sure.
Great. Okay. Thanks a lot. Hi everyone. Thank you very much for joining on a Friday evening. So I'm not going to keep it a boring session. We'll just quickly talk about more practical aspects rather than going to a theory kind of talk. I would have liked an interaction, and feel free to just stop anytime if you want to talk. I would like to know who are all attended, but this Zoom kind of thing is not the best way of connecting with each one of you, right? So that's my phone number and email. I do wear multiple hats. As mentioned, I am a pediatric intensivist, and my core expertise include ECMO training and organ transplant in kids. I've worked in hospitals like in London, Southampton, Oxford, and finally in Royal Children's Hospital in Melbourne, which is where my most of the training in organ transplant was. I'm also a co-founder along with Shweta Shastri, who is my tech lead in DocCare, which is like a telemedicine and a research-based platform. And I do still do some retrievals, mainly for ECMO and ventilator patients. And for all those who are students and probably nursing as well as other allied specialties, we are also coming out with a website called Peaceicucom. Anybody who is specifically interested in pediatric part of ICU, feel free to, this is going to be live in about a month. I do a lot of simulation and training in recitation. So that's one more session, not only just nurses and junior doctors. I would want to talk to even like individual practitioners if they're interested in this, because this is an established program outside India. There you do have to go a training even if you're a GP. In India, somehow we just take a back seat. So I'll be very happy to talk to all of you and just talk about more like organ physics and physiology, how to take care of a deteriorating patient in general. I'm also a bit of an anesthetist from the background, so I'm happy to talk about all this. Now coming to just a topic for today, and I'll keep it very short, probably 15 to 20 minutes, and then we can probably interact with each other. Private practitioners in pandemic, the answer is probably different if you are a practitioner in UK and Australia, because you form the hub there. The government actually makes sure that you are the first point of contact for the patients who are out in community. You see them and you then escalate the care if required, or if not required for that matter. In India, however, it's every man for his own game. So you just have to make sure that your practice still goes on. And so how do we do that? I still believe, I think COVID did come. It kind of created a lot of panic, but it doesn't need to be. And some of the solution which I'm going to show you today was practiced by even private by individual doctors to manage COVID patients out in community. To answer the second part, how to help your patients as well as grow your practice, I think most of the solutions today doesn't involve the patient input, and that's where we kind of fail. I think you should, after you see a patient, the patient should do something, either from the technology point of view or just monitoring himself or herself at home. There should be something rather than just see you once and then come back and see you after 2 or 3 days. And I think the solution can only be understood once we have a very good technology in place. Just to show you the perspective of how DocCare kind of solved this problem, is like, there's a patient who develops fever and there's a lot of noise, in the 48 hours. All of us know about COVID. In fact, probably many of the patients have gone to YouTube and seen how to manage COVID. But I think 95% of the patients go into this kind of cycle where if they, by mistake, if the RT-PCR comes as negative and the symptoms continue to persist and they do another testing and then it comes positive, by the time they are diagnosed as positive, they've lost a golden window. They've lost that golden window where they could have been educated about how to manage themselves at home. They succumb to myths, they take irrational decisions, they just go on consulting multiple doctors. And doctors, what would happen? You don't get patients who come with a proper information, right? So you end up giving everything. In fact, we end up giving everything. We give ivermectin, we give whatnot medicines without understanding where the patient actually falls in the timeline of illness. Now with DocCare, because we allowed the patient to engage in monitoring the symptoms right from the time they get unwell. It's not COVID. It's for that matter, anybody who's got fever or suspected COVID, the app is out there. They download the app, they just start monitoring. And now the doctors in real time can actually make out if the patient is getting better or worse. In a way, you can form a program, which even individual doctors did, and kind of worked really well. This solution was nominated by Economics Time as one of the best remote monitoring solution for COVID-19. So my bottom line, and to give you an answer for those two questions as to how do you build your practice and how do you engage patient, is technology. The problem with technology, however, is that we are not ready. I think most of we as doctors feel that technology looks and sounds like this. I don't know how many of you know about these two machines, but the one on the right, this is called Enigma, and this was built by Hitler during the Second World War to generate codes in order to coordinate attacks especially on Germany. And this guy, Alan Turing, who is a British mathematician, he built a machine to decipher those codes, which was for that time very complex one. And you can just see how the machine is. This is actually a replica of the original machine, and it's actually from an English movie. but it almost looked like this. And when people saw it, they were very reluctant to use something which is like 1.5 size of a human being and to run it. And they thought this was redundant, but this was the reason why Nazis actually lost. And the point which I want to say is, if we don't use technology now, we are not going to actually grow. And to give you another example of what, I don't know how many of you know about this letter, which was written by Mr. Gandhi way back in the 1930s to Mr. Griffith, that time who happened to be a commissioner, writing something, I don't know, but if you go to Twitter and Times of India and many websites, they all have different versions of what's being written here. But we have been doing this. In fact, we as doctors still do it. We write it and we think that this will help. It doesn't. The technology did come in picture, like internet. That's the reason why you and me are able to talk today. That's the reason why without talking, you can see some text there and you can read and understand. I think we as doctors should adopt technology. And pandemic, the COVID actually acted as a catalyst. I think even the patients have now understood the value of telemedicine, which was not there before. And I don't think telemedicine was very well accepted before COVID happened, right? If we are somehow able to engage the patient and digitize their illness, there you go. You have the formula to actually take care of the patients using the technology. The problem is also that it's not that we don't have technology. You know, WhatsApp is there, email is there, phone call is there. And we think that these can actually tell you how the patients are doing real time. No, it doesn't. That's a conversation with permission from one of my patients who kept giving me a live update about her child. And it is almost like what Mahatma Gandhi wrote a letter. Like, I think this is what is happening in real time to the child, but the truth might be something else. So what happens with us in healthcare, and this is how I think happens in most of the OPD or in telemedicine, where a patient gets connected to a doctor and the whole story starts. I don't think telemedicine or connecting a patient and doctor is a challenge today. The challenge is this, that a patient who is on the other end starts telling the story that I have headache, I have pain for 3 days, I have cold, I have cough, and you as a doctor end up, making a story out of that, right? That's what is noise. And doc care allows the patient to, engage right from the time they are unwell, and the information which you get is actually signal. You take out all this noise and directly you start having a proper communication, which is the biggest reason why a doctor-patient relationship can actually grow. The consequence, as I told you, it does cause exhaustion. You don't end up spending much time with other patients. We end up doing blanket therapy. If you just come and say cold, cough, headache, fever, and I'm miserable, and you don't give me a proper timeline, we usually end up giving a lot of medication. But if this patient was monitoring the symptoms right from the beginning, those symptoms would have taken a form of a trend, and that could have helped this doctor to actually give what we call as a personalized treatment. Now, also, this is just from the commercial aspect. That what at least from the doc care, what we have done is we have made a B2B solution. So once the patient is connected to this doctor, there's no searching of other doctors and other connections. So this patient can only take consultation with this doctor. And we introduced this program called SMART program, which is the patient does symptom monitoring, the app does analytics, and the doctor can actually do remote treatment. One of the successful reasons I think we can build both the private practice and allow the patients also to be happy is using a hybrid model. So we don't have to do all the consultation like online. Some of this can be offline, and doc care actually engages the patient in every aspect, be it for offline or for doing a consultation inside the OPD and even after the patient leaves. And obviously, there are advantages which include personalized therapy, higher retention, and obviously faster consultation. That is to show you how the apps work. So we created something called as modules. So the app can be used by almost any category of patients. In fact, pregnant mothers, elderly patients, those who have had heart problem, diabetes, asthma. There's actually a solution which is inbuilt in the patient app. And when they actually select one of the modules, those modules have pre-selected symptoms, like what you are seeing is a fever module which has been used for COVID monitoring. So any patient who thinks or who is diagnosed as COVID downloads the app, has these symptoms, and now monitors the symptoms on a scale of 0 to 10 using simple emojis. This is a kind of a tool which is helping patients to not have a medical knowledge. We use these emojis even to rate our experience in hotels or food or say what not. So we use the same emojis for healthcare. So nose block on a scale of 0 to 10 at right now, for example, 4 doesn't sound that bad. And when the patient interacts with the app multiple times, you have the trend of the illness which forms. And this is what you can see as a doctor, that this patient's fever is actually trending down. I feel the power is at this point, if this patient consulted you, there is no reason to give antibiotics. That is the power. If we can actually reduce the amount of medication, if we allow the patients to actually monitor, you are doing benefit not just to the patient, but you're also building that confidence and you're building that ecosystem. I think that's one of the biggest point which actually doctor can solve for individual doctors. And this is just to show you flow, where the patient, once they download the app, they scan the QR code, and once they consult a doctor, they can do a video consultation. They can do extended package. So many of us would like to give a prolonged package like 2 weeks or 1 month. Some of the obstetrician might want to be connected with the patient for 6 months. Even that can be done. The patients can continue to monitor themselves, and that data can be seen in real time by the doctor. The doctor also actually has the capacity to build his or her own team, and that kind of helps in improving the efficiency. So many of you might have maybe a junior doctor sitting with you, so you can build a team who can actually help you with adding the patient details and generating a prescription which doesn't go directly to the patient, but it comes to you and then it goes to the patient. So a lot of value in having this kind of a B2B solution. Other features like prescription is very, very unique, because once there's a lot of patient data which automatically gets pulled. We as doctors don't like writing. If the technology is there, it's actually able to pull this information and get it on the app itself, it kind of improves the efficiency almost to 50-60%. And of course, the other parts are like how doctors can do a routine prescription. So overall, I feel one way to move forward is to digitize the practice. It's like how we say that I don't need insurance, but you do need insurance. That's the right thing to do. You should have a hybrid model. Don't try to take any consultation which is purely online. So we do need to make sure that we have some kind of offline consultation on those platforms. We need to have some way of capturing those patients once they have consulted. So post-consultation monitoring is another important aspect. And obviously have a combination of a paid and free options for the patient. You don't want to always charge a patient. At the same time, giving always free consultation is not probably useful. I don't know how many of you do WhatsApp consultation and what's your experience has been. From my experience, it does help you build your database, so the patients are kind of connected to you for a longer time. They're not always ready to actually take a paid consultation, but there's sometimes patients have been offering on WhatsApp to pay. From the telemedicine point of view, there is nothing wrong in doing consultation on WhatsApp as long as you follow the telemedicine guidelines. So if you do have your own prescription and it follows the telemedicine guidelines by India, then you can still take a picture of that and put it. And if that generates some kind of revenue for you, so be it. But if you have another technology platform associated with that, the WhatsApp does allow you to put a profile of that. For example, you as a doctor might be with certain businesses, some third-party services like doctor, so that can be showcased. But bottom line is engage the patient, show them that there is something else they can do once they leave the platform, so that there is some connection which they can have once they leave your private practice. I want this to be more interactive. I want to know who are people who are actually doing private practice. Probably you can just raise hands there so that I can see, or you can even, if your mic is open, then you can even talk. I want to know, how did you guys manage COVID? Many of you probably have used WhatsApp to do so. Was it useful? Did you have any problem? Is there something you can, share with others? Dr. Bharat, if I could point at you. You're on mute, sorry.
Why the children are less affected in corona?
Yeah, good question. We don't know yet. There are a lot of hypotheses which are coming out. Maybe some school of thought say that the ACE inhibitor, that particular receptor, are not well developed. That's one school of thought. I wouldn't vouch for it. The other thing is probably there are antibodies because of the MMR and chickenpox, which is what most of the kids get, has some kind of a cross protection. So influenza, MMR, chickenpox, these are all kind of viruses, and especially the flu virus has the kind of similar receptors as compared to the COVID. So there might be some element of cross protection. BCG, which was thought a lot that could produce some kind of CMI. I'm not sure, but yes, people have spoken about it.
Anything else with the immunity? There is the immunity is not properly matured. Immature immunological app of children.
Yeah, it's unfortunately, we don't have a scale like a 0 to 10 to say how mature, immature immunity is. Like right from the beginning, the kids actually, if in general, get more cold cough, right? But that's part of the growth. If they get more cold cough, they develop more antibodies, and over time, they become more immune. So you're right. In some way, you need to get exposed to certain viruses and bacteria for the body to recognize and produce antibodies. But in general, it's not that they have weaker immunity. It's just that they've not been exposed to a new foreign antigen.
Okay, thank you, sir.
Did you manage any COVID cases, sir?
So many courses. I am working as a professor of pediatric in Gandhis Medical College and Hospital at
Beautiful.
Lahore.
Beautiful. Beautiful. Yeah, you must have seen some cases. I'm sure even pediatric COVID cases are coming.
Yes.
Yeah, so I think for most of the time, how I have managed is watchful, wait and watch and see. Only if they start deteriorating. So of course, how do you define deterioration, right? How do you tell the mother no what is deterioration? Because you can't do a pulse oximeter for a child many times. Pediatric COVID is a slightly tricky one. I think over time we will understand, but I don't think it is any different from a bad flu, for example, especially in kids. I think teaching the parents is very important. People think they know about COVID. It's that golden window which I was talking to you about. Teach them what to look for, give them a tool for them to monitor so that they can be in touch with you. And if the temperature starts getting high at the end of day 3, day 4, probably do a set of bloods to see how inflammatory they are, and then think of second line of treatment. That's how I managed kids in COVID and kids. Any medical students who are out there who have any questions? So at least from the medical students' point of view, do register on peaceicucom when it comes, because I have a team of doctors and we'll be doing live simulation. Dr. Bharat, it might be useful for your students also when when this program goes live. We will be doing, so we have learned, we use some simulators and that can be shared on a screen. So we can build up a lot of case-based scenarios, like a deteriorating child in the ward or a collapsed child who comes. And for that matter, anybody from anesthetic one, there are a lot of organ-based programs which will be coming with, and it's all free. It's all about building that kind of knowledge. So do let others know about it.
And also resuscitation program.
True. Yeah, it is so important. I'm sure if suddenly we ask how would we use defibrillator, I think everybody they've forgotten. I don't think we are very confident in that, right? We don't know whether what is pulse lead, what is VT, what is VF, how to diagnose. So those kind of programs will all be incorporated in this. Any other doctors who have managed COVID firsthand, found some difficulty, and you want to just throw some light on that? I wanted to keep it very short. I don't think so. My bottom line from this whole lecture is not that you take doc care. I want all of us to know that you need technology if you are going ahead, and if we feel we are scared of it, I think we should start adopting it, because once you start using, I'm sure I don't know how many people still email. They will still write that on WhatsApp, and that's because we have adopted WhatsApp. So once you start learning more and more, I think it becomes easier.
Saif, we have a question on the chat from Dr. Pratyusha, if you want to just answer that question.
Very good question, Dr. Pratyusha. Are there more variants to be expected? What can we do about the misinformation, the resultant panic being created? So apt, right? To answer your first question, are there more variants expected? Think of it as in particle physics. When you have a lot of collisions happening, you have new generation of particles. If you allow the viruses to be out in community for long, quite possible the virus will mutate, and at the end of the day everybody wants to survive, and even viruses will do that. So they will mutate, you will have variants. We hope, and generally, the general rule is mutations usually kind of make the viruses also more friendly with the host. If the mutation actually kills a host, then that's a dead end. Like it's like in rabies, it's not going to actually propagate in population. But in general, mutations, hopefully, and I could be wrong, it could be that one mutation suddenly happens to challenge our immunity, and it could be a bad one. But in general, yes, they are usually weaker. What can we do about the misinformation? I don't think misinformation is a problem only in India. I wouldn't say. I think that's the first thing where everybody wants to say that in India people are not educated or they're not. Well, this is a problem across the world. Even if you go outside, even people in UK and Australia don't believe in vaccination. But it's that constant effort by people who actually have domain knowledge. I think people who actually represent, like at least the ministers and higher level of political people should kind of give that information. If I say, wear a mask, I don't think anybody will listen. But if the government says, and we as a nation kind of give the same information, then that probably percolates more deeper. Panic, right? I think, as I said, one of the last resort is we as doctors. Ultimately, they will come in contact with us. I believe one of the reasons why the mucormycosis cases also went up is because I think there was a blanket statement saying use steroids, or steroids have helped, or remdesivir has done something. So everybody went to black market, bought that, and took it. We still know that if you give steroid in the first 5 days, you are actually suppressing your immunity. You're allowing the virus to actually replicate more. Steroid is a dual-edged sword. It can actually kill, it can actually do a good job. We know about it, but it doesn't go to the patient at the time when they need to know. So that golden window in the first 48 hours, when they become positive, and if we are able to capture them and let them know that it's all right, you've got COVID, this is what the steps which you have to do. That's how what doctor does through, doctors talking to the patient and getting them on program. I think that could be, a game changer.
Sir, my one question, other
Yes, sir.
than this today's subject, you are using one near infrared spectroscopic probe to measure venous saturation to prognosticate in neonatal resuscitation. Near infrared spectroscopic probe. Is it useful?
Is that for guiding the outcome of
to
of
measure the
resuscitation?
venous saturation,
Yes.
or to prognosticate the neonatal outcome, and also cyanotic CH3 in case of children.
Yeah, a good one, Dr. But it might be the out of scope for many other, but I'll just tell briefly. NIRS is a very known technology for last about 30 years. It's a probe which you can attach to a skin, and usually you keep, at least in newborn, on the forehead near the anterior fontanelle, and you can keep even on the other parts of the body. What it does measure is mixed venous saturation, Dr. Bharat. So
Is
we
it
use
available?
it's available. Yes, yes, absolutely. It's available. It's a very routine practice for all the kids who have had, let's say, cardiac surgery, not necessarily more of acyanotic, but all the cyanotic heart disease, when you do all the suturing, you want to know the mixed venous saturation. So this is a
because I am working in tribal region, there is a prevalence of sickle cell anemia. There is a chronic hemolytic anemia leads to chronic hypoxia. So I want to measure the venous saturation in these children. Is it useful?
If I have to answer that in one line, answer is yes and no. One number is never going to help you mix venous saturation. It's always the trend. So if you put a mixed venous saturation in a kid, it might give you, say, answer of 95, but that could be a very transient. In general, it is probably more 80, 85. So mixed venous saturation is always important when you are continuously monitoring to see the trend. If that is going down, then your cardiac output is not good, so you need to fill the patient. And it's very important again in resuscitation. Using this out in community for kids like sickle cell, I'm not sure what is the outcome. I'm happy to discuss about that,
I want
offline.
to study about the chronic, this hemolytic anemia leads to chronic hypoxia, and what is the impact on growth and development of children.
Very good. Very good.
Can
Very good. You'll have to do a pilot, because even in hemolytic anemia, you don't get hypoxia. Hypoxia is there, but it's enough to cause the bone marrow proliferation. So you do have more RBCs coming in, so that they're not actually hypoxic. So picking that kind of number on a NIRS might be difficult, but maybe we can go through the study detail and do a pilot and understand what kind of data is there. So very interesting, Dr. Bharat.
Right. Thank you, sir.
Thank you, sir. Did I miss any other question by any chance? As I said, I didn't want this to be a boring lecture. If there are questions which you want to ask about how to manage a case of COVID, for example, I myself have managed COVID, pediatric COVID as well as an adult, because I happen to work with adults also. So I have done that. So if you have any questions regarding COVID management, I'm happy to take that. As well as outside this, that's my phone number and email. So in case if you want to do some kind of research related activity or get into a program to teach more medical students and doctors, feel free to reach me.
Sir, Dr. Sundaramurthy here from Chennai, Adyar.
Yes, sir.
There was a thought or saying that certain blood groups are prone for COVID-19. What is your observation on certain blood groups, COVID-19 and complication? Do you have any data?
Yeah, I have heard about it. In fact, the way I would see it, what is it that is going to change in terms of managing that patient? Probably no, because you have the O positive being the majority. I don't think there is enough data to actually give you a very strong reason as to which blood group can have a higher mortality. But if you ask me personally, from the management point of view, it's not going to change my management. If it does, and if it is one of the predictors, I would like to do the blood. But I did read that paper, but I'm not a strong believer in that. What do you think?
No, sir, there's only observation, certain people, but it has to be done in a large scale.
Correct.
Only few observation cannot be taken as a, you cannot generalize a statement. I agree.
True.
Thank you. God bless you.
Thank you, sir. Thank you. Anybody felt a very challenging COVID case out in community? Just to share, I would like to know how did you manage it? No volunteers?
Sir, more than COVID, actually now post-COVID is a threat to the general practice, because anything patient come to us with any complaint, either headache or leg pain, whatever, I think that now it's a challenging. Every patient is asking, "Na vaccine போட்டேன், இதனால இருக்குமா? COVID வந்து அதனால இருக்குமா?" So many patients are asking this type of question. What should we do and what is your approach?
Absolutely, sir. Very difficult, right? Because see, out there in the community, even if they get headache, I don't know how even how should we define the post-COVID syndrome? I think 50% of us, including myself, will have headache at some or the other point, and I might relate that to COVID. And if I read in newspaper, there is something called post-COVID, my headache will only increase. So I think symptomatic treatment is most important there. As long as the saturations are good, the patient is not oxygen dependent, I think a lot of CBT, the cognitive based therapy, is probably going to make a difference, because end of the day, what are you going to do about a patient who complains of a lot of myalgia and headaches, for example? It's a CBT which makes a difference. So more of a psychological support, little bit of symptomatic treatment, but obviously there is no specific medications which are available to treat that. But lungs, that is something we have to be very careful about.
Currently, there is a message combining vaccine, Covaxin and Covishield is a better.
Yeah, it has come.
Start asking.
Yeah.
What is your?
Yeah, it has been approved. I wouldn't say that on this platform at this stage. From my understanding, that it has gone through approval and they would like to do it. But I think the things might change. You know how remdesivir was spoken so much about, and although in our doctor circle, you and me knew that it's a very
literally thrown out.
Absolutely. And the problem is that communication, when it goes to the patient, they say some doctor has told Rem and you are saying no, what is this? Now everybody knows the truth. So again, about this mixing of the vaccine, I think if anybody who asks anything related to COVID, the way I say is, first and foremost, get vaccinated. Let it be one vaccine that has been proven. If whether mixture works or not, one vaccine has proven, so do that. Second thing is mask. Third thing is, don't think that you are immune, because mutations can happen. You revolve around these 3 points, talk to any patient, we'll be able to, take them into confidence.
Sir, all of us had first and second dose in January and February. Agree, sir?
Yes, sir.
What about the third dose? Should we have? Now almost is going to, we are going for year end. Should we have or not? The question is,
as of now, I don't think there are evidence to say that third dose. So I got my antibody testing done because I was part of another study, and the antibody levels were very good. It was actually in triple digit. So the only time can tell, but as far as the studies from UK and Australia have shown, the titers are pretty good even as of now. So the third dose is not there as of now.
You are mentioning about neutralizing antibody, right?
Well, protective antibody, whether they're neutralizing or not, only time can tell.
Anderson did a free estimation to all the doctors. I think you'd be agree. So it was around 250. Should we redo?
Yeah. Sorry. I'll just take one more question from Dr. Pratyusha. What are the major deciding factors in a COVID person's recovery after invasive ventilation, and what is the survival rate? Pratyusha, good question. See, I wish the treatment is, it's I think as a team, how you're managing the patient is the number one deciding factor. And I'm sure many of you will agree that even if you have a COVID patient who's right, your neighbor, The way you manage that person is going to be different from 100 other patients who are coming, because it's not possible to give personalized treatment. If you have, see, but once the patient goes on ventilator, for example, and has got 70% lung involvement, what do you think is a deciding factor which will make sure that he doesn't go into more complication? It is a lung physio. It is to make sure that most of the lung is aerated and oxygenated, which means you need a dedicated person to do a proper sectioning every 4 hours. You should rotate the positioning. You should also see which part of the lung is involved, and therefore make sure the ventilation perfusion is kind of matched. For example, if I have a right lung which is completely gone, and if I put the patient right side down, most of the blood is going to the right lung, so I'm not actually ventilating the patient. So very small factors like this does matter, and I wish there was a very, if there was only, if it's a very small pandemic, we have 5 nurses, 4 doctors, and 1 patient, like how the president of US had. Well, fortunately, he didn't go on a ventilator. But if you have that kind of cocktail, the outcome can be really good. And this is what I believe. So in our own hospital, for example, Dr. Bevin, who heads the emergency department, he's got a very different threshold of intubating a patient. If the lungs are getting worse very fast, he intubates fast. He keeps them in the emergency department. He has his protocol running, and they keep recoursing as and when required, and lot of suctioning, lot of physiotherapy, and that actually can have a good outcome. Survival rate, again, very varied as per where the patient is. So if you are in a setup where you're looking after 10 patients, just imagine there's a single nurse who has to see 4 patients. I'm not sure what kind of quality care can she give. The medicines are not going to be that effective. While you give steroids, you will give antibiotics, you'll give antifungal, but ultimately it's the physiotherapy, it's the constant care which is important. So again, survival is very different depending on where you're being cared for. But in general, at least during the second wave, I was very disappointed. Many of the ventilator patients didn't make, but that's also because they took steroids early, they took wrong treatment, they remained in denial, and they presented to the hospital late. If you want to change that, I think educate the patients, have an early warning system, escalate the care early, go to a hospital early, and that can change the outcome. I hope that answers your question, Dr. Pratyusha. Any other questions? Do let me know if see, I do a lot of simulations, and that is a practice which I've done for almost 10 years. So we just produce a scenario. For example, there's a child who walks in right now and collapsed. So what are you going to do? I don't know how many of you would face a situation like that, but when you deal with a situation like that, that helps you in managing slightly lesser, sicker cases. So if you, any of you are interested, do ping me or mail me. I'll be running programs like that, and I would love to interact. I would want to talk to you guys as to how you're doing and what else can be done. For example, do you have any suggestion which a government can do, which we have not done? We can just brainstorm about that.
Sai, there is another question. It's from Dr. Lalita Joshi. She asks, can pregnant ladies and once those who are breastfeeding get vaccinated for COVID? Is there a research study fortifying it?
Yeah, I don't see that question here. You said Dr. Lalita, is it?
Yes.
Okay, thanks, Dr. Lalita. Breastfeeding, 100%, it's been, there are studies by, I think, even on Foxy website, a very clear statement. There are risks and benefit of a vaccination, but the benefit outweigh risk. So as many mothers I'm meeting and as many people have asked this, definitely we're asking for them to take the vaccination. Now, early pregnancy is a slightly tricky situation, and I'm not aware of what is the current guideline there. We do, I do know, at least from my OBG counterpart, when they say, what would you do if you have COVID right at the time of organogenesis, which is like the first 6 weeks? I don't know. it's probably a very tricky situation. You can't do anything. So maybe an expert opinion would be required. But definitely, I can tell you, breastfeeding, yes, there is no contraindication. And in fact, you are probably giving more benefits by giving antibodies to the baby by vaccinating yourself than not. Involve, I don't know how many of you do that. I'm sure you would, but I do involve many of the parents also to do a decision making. For example, when I give vaccination, the first time when they get the baby and they say, okay, in 6 weeks you're going to come, so I clearly make a statement: read about vaccines, know what is painless, what is painful, and if you don't read, I'm not giving the vaccine. So they do their homework and come back. And again, vaccination is not an urgency, right? For example, COVID vaccination, you do your homework. Why don't you read from your side, and I will guide you what needs to be done. So do involve the patients in taking some decisions.
Hi, there's another question by Miss Kritika. She asked, since everything is digitizing these days, do you think doctors...
Sorry, Sushmita, you're not very clear. Sorry.
Okay. She asks, since everything is digitizing these days, do you think doctors should go online? If yes, how can social media help doctors in growing their practice?
I didn't hear the first part still, Dr. Sushmita. What was the first part you said?
Since everything is digitizing these days, do you think doctors should go online?
Okay, and what's the second part?
Yes, how can social media help doctors in growing their practice?
Perfect, thank you. Thank you so much. And that was Dr.
It's Miss Kritika.
Miss Kritika. Thanks, Miss Kritika. So, digitization itself is a scary word, right? In all fairness, if the moment you digitize something, it's digitized, so it's there forever. But if you see the whole, how humans have evolved over the last 10,000 years, the computers came in only for the last about 70, 80 years. And like, for example, I don't know how many of you know iPhone. It was launched only in 2007. Before that, there was other phone. I still remember in 2000, first time when Motorola came, it was a big bulky phone. So technology will ultimately come into everyone's life. I think we should adopt technology. How much of the technology should penetrate what you're doing is something I think everyone can take an individual decision. So digitization will actually help you grow over time. There is no doubt about it. And I would say there is nothing wrong in even going over social media, as long as you, as from the practice point of view, you are protecting yourself also. So it's not easy to prescribe anything on a social media, right? For example, right now, can I actually prescribe Dr. Sushmita something by doing consultation? Well, yes, if I have recorded this conversation, if I have seen her, and in my prescription, I do write very specifically that the prescription has been generated based on a teleconsultation, then why not? But blindly giving a suggestion to someone can easily backfire. So I would say find to what depth you want your practice to have technology. Do have an online and offline platform, and do take care of all the telemedicine guidelines, because that is eventually which is going to protect you. Don't think by not digitizing you are not, you will be safe, because when you write a prescription and if it doesn't follow the guidelines, something touchwood happens to the patient, and if that prescription comes back, in fact, you could be in more problem because it's not digitized. So if it looks like Mahatma Gandhi has written something, which is what my writing also looks like, well, eventually the medical council will ask you that your handwriting was not correct or it was not legible, and so you will be held liable. So yes, we are living in an era where everything can be questioned. So do have some amount of digitization, and yes, social media do take care of all these precautions. Kritika, I hope that I answered that question.
Yes, doctor. Yes, you did. Thank you.
Thank you. Anybody saw any unusual case? I don't want to bug all of you. This is almost going to be 6. Any very, very interesting case you saw in a COVID which you want to share? Okay, not much. Soumya, you think we can conclude, or?
We can check for any more questions left. We can. One moment. Let me just check.
Sure. Dr. Bharat, I would like to connect with you offline, if that's okay. We'll discuss about your study also. Sounds very interesting. A platform is being used to run an all India thalassemia program also. So a
Okay.
group of hematologists are actually tracking the journey of kids from the time they get blood transfusion to how many transfusion, to understand how much they're developing the phases. So the platform itself is also adding AI and ML. So it's actually helping the doctors to track the journey. So we can talk about that as well as about your study.
I'm more interested in this preventive and the treatment protocol of the sickle cell anemia.
Correct. Very nice. Very nice.
And also see the impact on the growth and development of children.
Beautiful.
So the preventive aspect of the sickle cell anemia to prevent the severe acute malnutrition. Because in malnutrition, there's a recurrent infection and precipitate crisis.
True.
If you correct dehydration due to diarrhea and correct hypoxia due to pneumonia, already there's a no need of any other hydroxyurea or anything else.
True, true, very true. I think it's all about, again, how do you know what is happening to the child when he or she is not connected to you, right? So can
Right.
we, if we had that information, which is what is going to happen in 100 years, by the way. I don't know how many of you will believe this. The technology is going to be so pervasive.
Right.
We can only talk about something which might sound as fiction, but tomorrow it will be truth. That you, as soon as you're born, you come with an implant, and that will give all your data sitting somewhere, and you might even live for 200 years. But I hear you, Dr. Bharat. That's a very interesting study which you're doing.
Very glad to hear you.
Thank you. Thank you.
Sai, we have two more questions.
Yes.
One comes from Mr. Borun. After vaccination given, some patients grow COVID severely. Why?
So very specifically, how do we? You're saying that if they get COVID after vaccination, they're more severe. Is that what you're saying, Mr. Borun? Because I don't know how would you. So you'll have to do a lot of um, patients tracking to understand how many. So, for example, this patient probably would have got COVID anyway in a severe manner. So, how is it related to vaccination? And again, the timeline. So, I'm not sure after how long of the vaccination you're talking about patient getting severe COVID. All in all, how is it going to change our management? So we would still say, again, as I said, those three mantras is that you should vaccinate. If you do get COVID, well, yes, get onto a program, monitor yourself, identify early risk factors, do not take steroids, and head to the hospital by day 4, day 5 if your fever is not getting better, is how I would see. I'm not sure if you're saying you've written after vaccination given some patient grow COVID severely. I'm not very sure if that's directly related to vaccination. I have one more question. Post-COVID, loss of sense of smell and taste can be jarring and emotional. How to manage such patients? Tell me, Dr. Basra, you have a solution for that? Let's brainstorm and come out with a solution. It is, in fact, I've heard that from a couple of patients, and it is very annoying. At least from the literature, I haven't searched it myself. That is it a permanent entity? I don't think it is. It does cause emotional thing. I'm not sure if anybody can actually have a very, because there's no medicine to treat that anyway. So that much is something I can tell. But whether a CBT can help, whether just counseling will help, make the patient say that at least living is far better than, if you had more serious and more lung involvement, kind of show the positive side. But no, I'm not aware of any medication which can actually help there. Dr. Pratyusha has one more question, I think. Do you think healthcare workers should be given a mandatory mental health counseling in order to deal with any of the stress and disappointment when the patient doesn't make it? So apt, Dr. Pratyusha, so apt. I missed this part where, and I won't boast because I've done my MBBS, MD, and even after that I've been here. But when I went to UK and Australia, the culture is so different that there is actually a counselor who's available for the medical fraternity. And it is so important that, some of the nurses break down, for example, when they see the child who were taking care of for a long time, and they can't take it, they just break down. I think it's the culture which is so important for us to know that don't accept death, be it be anyone's, and do support. I strongly believe that there should be counseling in place. And I think if you can't solve a problem at a national level or a state level, can we solve a problem at the silo level? So if you have an institute, you should flag it up and get one person to form a program which can help. I remember, if I'm not taking too much time, we had a program called FERF, F-E-R-F, and I have forgotten what does it stand for, something to do with some friendly thing. But this doctor in Oxford, she came out with a concept saying that, hey, if somebody has done something good, FERF them. And it sounded, I'll send an acronym, what does it stand for? But it's a positive remark. So, hey, you, like on a night duty, you got me a Coke, is a very positive thing, but you didn't acknowledge that the next day you've been FERFed. So that comes on a board, and then the maximum number of FERFs kind of stand out. So we deal with sick cases, we deal with cases who die, we deal with cases who are not cooperative. How do we keep ourselves from not becoming one of them? It's by we as a community forming a program like that. So positive encouragement, helping each other, and yes, mental health counseling, if there's someone who can do within your ecosystem, would be great. I strongly believe there, and I agree there also. What about COVID vaccine in kids? Will that happen soon? Well, fingers crossed. Hopefully, yes. We are really hoping that. The vaccines are already out there. Beyond 12 years, it's already out there. Again, one more information, which I feel everybody out there in community should know, that from today, how we are dealing with the pandemic is 50,000 times better than how we dealt with it 100 years back. So scientists are working on it, and when they come out with a product, it is not by fluke. So if scientists actually say that there is a vaccination done, and there are risks and benefits, but we are happy to come to a community level and give the vaccine, I think we should give it. So vaccines have already been introduced for kids beyond 12 years. And tomorrow, if it starts coming and percolating in our system for even smaller kid, I'll be the first one to take my kid. I mean, I would still believe in science. I would still say the benefits outweigh the risk, and we should give. When exactly it's coming, I'm not sure, but I think in the next 3 to 4 months, you should hear something at least for adolescents beyond 12 years. I think a couple of vaccines are coming, but for younger kids, we still have to see.
Sai, there's one more question. I'm having difficulty finding out who it is. Tracking of patients through doc care. Share some thoughts.
Yeah, so this tool, DocCare app, is a free app. Patients can download it. There are various modules. One of them is called fever module that has symptoms of COVID, and they can just go on monitoring many times a day. That's the end of the story. That's all they have to do. If they are connected to a doctor, the doctor can see that trend in real time and can actually give the treatment. But you can all download that app. Maybe you can just put a link, Shweta, and they can all download the app. It's free, and you can just see how it works. So you can educate your patients also to do it. Now, you don't need to be a doctor on this. You can ask them to monitor, and when they come back next time, they can show you the trend. Or there is also a feature which we are coming out very soon called as download report. So patients will sit at home, they will monitor, they will download the report, and they can even WhatsApp you if that's what something which you do, then that also can be done. I hope that answered the question of tracking. And I think there's one more. Do you think herd immunity don't work? Herd immunity does work. I wouldn't say it doesn't work. It's almost, see, if there is a disease which is out in community and it transfers from a patient to patient, if that is a route of transmission, then herd immunity will also follow the same route. So, for example, if there is a polio outbreak, there can be a huge number of patients who would get affected. If there's a H1N1 outbreak, there's a huge number of patients who will get affected. Herd immunity also is the same thing. So you will get some antibodies which will percolate into the system. To what extent it is going to be protective? Well, mind you, all of us are facing this pandemic for the first time, all of us, including the scientists and including we as doctors and this one. So a bit of a time will actually answer that. But I believe it does. And if we have at least 70% of our population covered with vaccination, I think the herd immunity concept will actually kick in. One more question. Can you share some thoughts on how this Delta variant is going to take over compared to the previous variants? Your view on third wave in India in the present wave scenario. Again, we will all speculate to accumulate. As more and more data starts coming in, we will know how things are happening. The Delta variant has caused more chaos right now in US. I don't know what's going to happen in India when it does come, but we might behave differently as compared to US. We have always done that differently as compared to the Western one, probably because, I don't know, maybe BCG, maybe tuberculosis, maybe the type of hygiene we have, maybe the type of antibodies we have always been exposed to. Our outcome has been different from US one. So whether Delta will actually cause more mortality or not, I'm not sure. But again, my answer would go back to same thing. Vaccinate, protect yourself, don't let the guards down. We just have to ride this wave. If we ever think that, Delta variant is a very mild variant, take the mask down, that's when you'll get the answer to that question. And you don't want to do that. How to be part of the case study program you mentioned previously? Any website link? Not sure with that question. Case study program. Dr. Sushmita, can you, what case study program did I mention? Oh, are you talking about the website, the peaceicucom?
I'm not really sure, Dr. Sai. Dr. Mehtab?
Oh, okay. From the Pete's ICU. Yes, he has replied, Dr. Mehtab. So your question is how to be part of case study programs. So DocCare as a platform is also being used for doing investigator initiated studies. In fact, 2 studies have already been done. So for example, if Dr. Bharat would like to track 100 patients of sickle cell and understand their journey, then that can be converted into a study. So there are all other features of study like e-consent, encryption, everything is in place. So we are, partnering with researchers also to do a study. So that is one aspect. But on peaceicucom, we will do simulations. Lot of real life simulations. So a patient suddenly collapses next to the beach. What are you going to do? A child who is in ward suddenly starts having fits. What do you do? A patient who has just come out of theater is hypoxic. How do you escalate the case? So I think the more and more we talk, we strengthen our concepts and we start applying it. If you read this from the books, I don't think we remember it, but simulations actually help. I hope that answered Dr. Mehtab. And how to be a part of it. Yes, so I've given my phone number and email. I'll be collaborating with more and more people, and these lectures are going to be like free. I'm just going to get more and more people involved, including from Australia and UK, who will do case-based scenarios. And if you have any specific domain like orthopedics or OBG or any other department, let us know and we'll include that. Do you provide training for private practitioner for using the app? How for tier 2 and tier 3 city doctors to utilize? So do we provide training for private practitioner for using the app? Very much yes. So we have a team. In case anyone who wants to use this app, then we get onto a one-to-one session and train them how to use the app. The second part is we don't do mixing, so it's not like one platform has many doctors. So the day you decide that you want to be a doctor on this, you get trained. You put your code either on your WhatsApp or Facebook or out in your clinic. So anybody who comes can scan this QR code and is now your patient. So this patient will take consultation only with you. Whether you want to build that practice or not is completely left to you. But yes, we do have people to train. And for tier 2, tier 3, absolutely. If you think your patients would want to take this service, why not? I mean, just display the QR code, or you can have a pamphlet, or you can put this on your website, and anybody who sees that can actually scan it and they become your patient. So you can grow your practice. So we are actually going to more of tier 2. We haven't gone to tier 3 kind of cities, but anybody who is interested, definitely I'll be happy to talk to them. Any other questions?
Sir, role of vitamin D in corona as a pulmonary immunomodulator, is it true?
Very good question, sir. I'll say you can say role of vitamin D and blank, and that question will be in everywhere. Role of vitamin D in hair loss, in skin care, in cardiac disease, everywhere vitamin D is there. It is a hormone which is now available as tablet.
Okay.
That is the truth, right? So any hormone you say, it's only available as injections, except thyroid and vitamin D. So it is there. I'm not sure if you. This is where the whole world is divided. Some feel that it may not be. Some feel that it is a strong one. My answer would be keep it normal. Like don't try to go and test your vitamin D level when you get COVID.
Right.
Well, why not maintain vitamin D level normal, and then whatever happens happens. You don't want to anyway maintain the level of anything above normal. But as I said, the answer to your question is why pulmonary. Even cardiac people are talking about. Even neurological people are talking about. So let's try to maintain vitamin D in normal levels. But I don't think it doesn't suddenly cause a big change. Is what I believe.
Thank you, sir.
Thanks, sir. One more question. How do you tackle elderly doctors to use doctor? There is no elderly doctor. I'm also old doctor here. Everybody is elder. There is nothing called elderly doctor. I think it's the willingness to learn. I think it's like if we can use WhatsApp, we should be able to use anything. Very happy to just sit and talk to you and show how this app works. Remember one thing, and this is what I believe: everything is difficult before it's easy. Like the first time we started learning guitar playing, it's very difficult. You can't play anything, and then you go on playing, and then you start forming the music. So it's all about diving in, trying to understand, learn, and if it becomes too much, stop it. If you learn, then why not? So I don't know. There's nothing called elderly. Is what I believe. I see the youngest person here is Dr. Bharat, who is so into, and I like that. So I don't think, agree, Dr. Bharat? I think you talk about it, yeah. I still do that. When I talk, sometimes the mic is off. So, it's learning. It's something which we can all overcome by learning. Any other question from nursing students or medical students? I think if there are no further questions, I don't want to bug others. But thanks a lot for joining. I still believe in meeting in a room like this, having one-to-one discussion, talking to each other, brainstorming. And I wish I could meet all of you, and I want to, meet as many of you as possible. So feel free to reach me for anything related to medical, and we can brainstorm and we can form programs and have solutions. But thank you everyone for joining.
Thank you, sir.
Thank you, Dr. Bharat. Soumya, anything else?
Doctor, do you want to check like if anyone needs demo accordingly, so that maybe the next activity would be arranging demo for the doctors if needed?
Absolutely, yes. I think we've left a couple of numbers and email also. So either they can reach that number or just ping me. Very happy to.
Dr. Sai? Dr. Sushmita, are you there?
Yes, Soumya, I think I got logged off for some reason. So yes, if there is anything further, we can. I think he logged back in.
Yeah, maybe if anyone wants to have a demo with app, maybe you can share the contact details once again, or if you want me to send out the emails accordingly, that also can be done.
Right.
Dr. Sai, your thoughts?
Yes, that's me with technology. I accidentally left the room. So there's nothing called. So I'm also in the elderly group. But no, so feel free to contact. So those numbers have been given, and just ping anytime, drop a message. More than happy to run a demo and talk about it further.
Sure, sure. So thank you, doctor, for joining us today on a Friday evening, as you rightly said, 5 to 6, good weekend time, and sharing your, experience in remote monitoring and even more COVID questions that we have dealt right now from technology and how the future is going to be. We look forward to your, continuous support and more activities and more, sessions like this. Thank you so much. And all the participants who are joined today, thank you so much. Yeah.
Thank you so much for doing, and thank you everyone. Thank you everyone. Very nice talking to all of you.
Thank you.
Thank you, sir. Bye. Sir.